Radical cystectomy with cisplatin-based neoadjuvant chemotherapy remains the standard of care for muscle-invasive bladder cancer. However, in carefully selected patients, bladder-sparing strategies can achieve comparable oncological outcomes, provided they are delivered rigorously within a structured, multidisciplinary framework. The International Bladder Cancer Group conducted a systematic, multidisciplinary consensus review to define best practices for bladder preservation in muscle-invasive bladder cancer. Firstly, histologic review by an experienced genitourinary pathologist is essential. Diagnostic reinterpretation can alter staging or management in up to 1/3 of cases, directly influencing eligibility for bladder preservation. Secondly, patient selection drives outcomes. The ideal candidate includes CT2, unifocal disease, no hydronephrosis, no extensive CIS, and good baseline bladder function. Importantly, more extensive CT3-4A disease, CIS, or hydronephrosis are not to be considered as absolute contraindications. Rather, they should be regarded as poor prognostic factors, guiding counseling and treatment intensity rather than automatic exclusion. Third, regarding outcomes, contemporary matched analyses demonstrate a comparable 5-year metastasis-free, disease-free, and cancer-specific survival between trimodal therapy and radical cystectomy. That said, approximately 13% of patients required salvage cystectomy, and when performed in a timely fashion, cancer-specific survival remains preserved, highlighting salvage surgery as a critical safety mechanism in bladder-sparing approaches. Next, bladder-sparing strategies require a maximal and safe TURBT. In highly selected patients, radical TUR alone must extend to the perivesical tract, strictly avoiding perforation, and typically requires repeat resection. Trimodal therapy should incorporate concurrent radiosensitization using agents such as cisplatin, 5-fluorouracil, mitomycin C, gemcitabine, or carbogen nicotinamide. From a radiotherapy perspective, the consensus supports modern image-guided techniques, selective bladder boosting, and moderately hypofractionated schedules, which are evidence-based and provide comparable oncological outcomes with acceptable toxicity, as shown in pivotal trials such as the BC 2001 or the RTOG 8903. Finally, bladder preservation following systemic therapy, including chemotherapy and immunotherapy, is promising, however remains investigational. The consensus emphasizes a strict and standardized definition of clinical complete response, requiring a negative cystoscopy, cytology, repeat biopsies or TURBT, and cross-sectional imaging. Despite rigorous restaging, occult residual invasive disease remains common, as conventional biopsies may underestimate true tumor burden. Multiparametric MRI is emerging as a valuable adjunct, while biomarkers such as ctDNA and molecular profiling show promise for refining patient selection, but require prospective validation before routine adoption. To conclude, bladder preservation can achieve excellent oncologic outcomes when delivered in experienced multidisciplinary centers. Pathology review, careful patient selection, and technical rigor are essential. Unfavorable disease features are prognostic, however, should not be seen as absolute contraindications, and a timely salvage cystectomy is fundamental to maintaining long-term cancer control. And finally, hypofractionated radiotherapy is an evidence-based component of contemporary bladder-sparing treatment, whereas clinical complete response guided bladder preservation and biomarker-driven strategies remain investigational.